facility, right, with the June?
Yeah, but it's not showing me the entire screen that I need to share. There are 3 screens, and it is. Let me just see if I can. Give me a minute.
You're on your laptop, right?
Yeah, of course.
Okay.
It's not showing me. Give me a minute. Screen 1 of window. It's sure. Can you see anything? I just shared my PowerPoint.
I'm on the phone. No.
Not yet.
I'm on the phone, so I'm not able to. I mean, I'm not able to see your screen.
Give me a minute.
Sure.
No, it's not showing.
You're now streaming. Now. Sorry, it's not going. Let me try it. I'm on the Chrome. Let me go onto the app.
Yeah.
And I'll come back.
Yeah. Yeah, maybe we can have Mr. Rakesh call or Dr. Soumya to, any one of you to.
Yeah, I'll share. I'll share. Just
I'll check. Yeah, so that we know that others, for them, it's working. Yeah.
Yeah, Dr. Rakesh.
Yeah.
Is it okay?
I think, yeah. But it is not, is it a full slideshow?
Wait, I'll just make it full also. Just give me a minute or so. Is it full now?
No, it's not. Yeah, now it's okay.
It's full, okay.
Yeah.
So
you can run.
I'll run.
Yeah. Run the slide so that
Okay, you can see.
Yeah.
So I'll stop sharing. Okay.
Yeah.
I'll stop sharing.
Yeah, maybe we can see with Dr. Ranjan.
Sure.
Thank you.
Yeah.
Dr. Ranjan, you can do it in the slide mode.
Yes, ma'am. Is it fine?
Yeah,
perfect.
Yeah. Perfect. Very nice. You don't have any videos or anything in this, right?
No, ma'am.
Okay. This is good. So only Dr. Vinu has not been able to connect. Dr. Anju, I think I'm not able to see you, but I think you are there. Welcome to the webinar once again.
Hi, hello everyone. I was just waiting for the slides. Keep going.
Yeah.
The screen is tilted. I don't know if you realize the slide screen is. Waving.
Yeah, it is hung. It's hung, I think, right? Dr. Soumya's slides have not gone off the screen. I'm not sure why.
No.
He has to leave. He has to stop sharing.
Just a minute, sir. Yes, I think it has been out.
Not yet. It's still showing. I think something with the Zoom. I think Dr. Vinu has joined. I think we are almost on the time, 7:37. Yeah. Can you check your slides again, because we are running late now?
Are these Dr. Soumya's slide?
Yeah. I don't know why they are not going away. I think Jitendra, would you like to check why the screen is frozen? Oh, no, I think it's better now.
Yeah.
It's okay now.
Good
I
now.
think Dr. Vinu, just check it once and then we can start, right? It's already 7.
Hi, can you hear me?
Yes, yes, yeah.
Where's the share screening button?
Bottom middle.
Bottom middle. It says multiple options. Who can share options? Share screen. Oh yeah, there it is. Okay, fine.
Green color.
Got it. Got it. Got it. Okay. Okay, what is this one? Okay, so that's okay. Got it. There it is. Can you see me now? Can you see the?
No, not yet.
No?
No.
No, not yet.
What? Okay, what about? So can you see now?
Yes.
Yeah.
Make it a, you have to make it a full screen after.
Yeah, that's what I need to do. Give me a minute. Slideshow. Okay.
Okay.
Okay, perfect.
Right.
I think we can start.
Yeah.
Yeah. Let's start it in that case. Dr. Vinu, you ready? Hello and welcome, everyone. My name is Anju Agarwal, and I'm one of the Gap Year EP members. Professionally, I'm a family physician in Australia, and I'm the deputy chair of the Royal Australian College of General Practitioners. So today we have excellent topic, which is, can you all hear me?
Yeah.
Yeah.
Yeah, okay. So the session tonight, I should say, is updates in imaging and treatment of glioblastoma multiforme. And we have three fantastic speakers, Dr. Vinu Agarwal, Dr. Soumya Ranjan, and Mr. Rakesh Kaul. And it is being moderated by Dr. Chirag Ahuja. So I'll briefly introduce Dr. Ahuja. Chirag is additional professor in Division of Neuroimaging and International Neuroradiology at Department of Radiology, PGIMR, Chandigarh. His special interests are neurointervention, endovascular treatment of cerebral aneurysms, AV malformations, cross-stenting, spinal interventions, and neuroimaging of vascular pathologies of brain and tumor imaging. So with this brief introduction, please welcome Dr. Chirag Ahuja and then all our fantastic speakers. Thank you.
Thank you so much, Dr. Anju. So we'll begin right away with the session. So it's my pleasure to introduce you to Dr. Sameer Vyas. He's the professor of neuroimaging and interventional neuroradiology at the PGI Chandigarh. He's a very avid neurodiagnostician as well as an excellent neurointerventionist. He has special interests in pediatric neuroradiology as well as brain tumors. So welcome, Dr. Sameer. I would request you to carry on the session forward.
Thank you, Chirag. Thank you, Chirag, for the introduction. At the outset, I would like to thank the team GAPIO, an interesting association, global associations of physicians of Indian origin. Thank you, Dr. Anju, Dr. Vinita, for making us part of this interesting webinar, the updates in imaging and treatment of the glioblastoma multiforme. The term glioblastoma multiforme, which was coined around 100 years back because of tumor heterogeneity, but recently in the 2016 WHO CNS classification, the term multiforme has been deleted and now it's referred to only as a glioblastoma. The term GBM continued as an abbreviation in the 2016 revised edition, but now in 5th edition summary 2021, the term has also been deleted. The glioblastoma is one of the most lethal human cancer and most common malignancy, and there have been a significant paradigm shift in the imaging and the treatment in the last 1 decade. Now, from the routine imaging, there has been the molecular and cellular imaging with coming into play a significant role in the diagnosis and the treatment of this glioblastoma. With this, I will, a brief introduction, I will introduce the first speaker of this webinar, Dr. Vinu Agarwal, who is consultant medical oncologist at Narayana Hospital, Gurgaon. He is a highly qualified medical oncologist treating all solid organ tumors with special interest in breast and neuroendocrine tumor. He has worked as research fellow at Royal North Shore Hospital in Sydney and Fiona Stanley Hospital in Perth. Dr. Agarwal has over 20 years of clinical experience, spans various national and international healthcare institutions, including in Australia and UK. Dr. Agarwal has actively participated in research and published in peer-reviewed journals, presented his research finding in numerous conferences and symposium internationally. With this, I invite Dr. Vinu for his first talk in glioblastoma.
Thank you, Dr. Vyas, for that kind introduction. And hi, everyone. Can everybody hear me?
Yeah.
Perfect. So let me just see this works, and everybody can see my screen.
Yes, yes.
Okay. Okay. So today we're going to talk about just a update and a review of glioblastoma. And we're going to start with simple basic plan of introduction of primary brain tumors, talk about the epidemiology of the gliomas, classification of the gliomas, which is the latest update in the 2021, the multiple changes, involving the molecular usage. And then there is glioblastoma clinical presentation investigations of for the diagnosis, treatment options of the for the primary presentation and treatment for the relapse as well. So starting with the introduction, brain tumors, we generally call, everybody uses it loosely to call anything that is a space-occupying lesion in this central nervous system. These include primary CNS tumors and secondary CNS tumors. The primary CNS tumors are can loosely be classified into 4 major types: the neuroepithelial tumors like the gliomas, which I'm going to mainly concentrate on. And even in gliomas, I'm going to only concentrate on the GBM or glioblastoma. Tumors of then the second is the tumors of the meninges. The third is the tumors of the cranial nerves and paraspinal nerves. And the fourth are the lymphomas, or the CNS lymphomas. The secondary tumors are more frequent than the primary tumors of the CNS. You usually see that they present as single or multiple space-occupying lesions in a scan. And as the name suggests, secondary CNS tumors means that the primary is in a distant location. The most common ones distally that metastasize to the brain are the lung, breast, skin, kidney, and the GI tract tumors. But there are a host of others that can do. Technically, the primary malignant cancers in the brain are rare. They are about less than 1.5% of all primary malignant tumors. However, the disease burden is quite significant. It's about 80,000 newly diagnosed cases are there in US, of which only 1/4 are gliomas. The most common primary brain tumor is the meningioma. However, the most common malignant primary brain tumor is the glioblastoma. And in India, the gliomas range between 5 to 10 per 100,000 of the population. The risk factors are quite loose here. The only risk factor that has been attributed to increasing the risk of your primary brain tumor is the cranial irradiation and high ionizing radiation. That was mainly seen in the studies that for follow-ups of the atomic bomb survivors in the Hiroshima and Nagasaki in the Japanese population. And then there are rarer risk factors like the hereditary tumor syndromes, which are really rare. And they, however, Li-Fraumeni, Turcotte, and neurofibromatosis do increase your risk of developing a primary brain tumor. The most commonly talked about risk factors are in the by Dr. WhatsApp or Google is about the environmental factors like the pollution, the non-ionizing radiations, the mobile cell phones, pesticides, solvents. Most of them haven't conclusively been proven to be associated with primary brain tumors. In my clinic, I'm talking about the mobile phones and the discussions around the mobile phones, whether there is a definite evidence for them to be responsible for the brain cancer, especially because the age population of these tumor patients is young, and they find it difficult to reconcile why they got the tumor and have to find a reason. So I always have to discuss this mobile phone, whether it's a risk factor or not. Whilst radiofrequency does have biological side effects on the brain, but there is no increase in incidence of brain tumors over time so far, in spite of ubiquitous use of these cell phones. Hence, there is no absolute evidence to say that mobile phones do increase your risk of primary brain tumors. Now, going on to the clinical presentation, the clinical presentation of the tumors is very variable. There's no single symptom that can be defined as that there is brain tumor because you have that symptom. It basically depends on the tumor localization and the size. Any of the symptoms of increased intracranial pressure, seizures, focal neurological signs, depending on where the patient is, like aphasia, paresthesia, hemiparesis, visual disturbances, or personality and mood changes can be the initial symptoms or progressive symptoms of the brain tumors. The glioblastoma, 90%. With regards to glioblastoma, they usually have short history between acute or subacute presentation with days to few months, whereas the low-grade gliomas have a longer history. Now, the diagnosis is basically made on MRI. I'm not going to spend too much time on it because we have a total separate talk on the imaging modality of the tumor. And I'm going to jump straight to the classification of gliomas because there has been a quite significant change in how we classify the gliomas. Taking to the historically, the classification 2007 was purely based on the light microscopy changes of the tumor biopsies. You had the low grade tumors and the high grade tumors, which we call glioblastoma multiforme, as kindly introduced by Dr. Vyas. And then 2016 was where the things changed and they started updating it and advised an introduction of molecular markers. Molecular markers like IDH1. IDH1, if I explain, is IDH1 mutations are mutations in the isocitrate dehydrogenase, which is the citric acid cycle, and it encodes the enzymes involving the cellular metabolism. And these mutations in the IDH1 isocitrate dehydrogenase genes lead to oncometabolite, aberrant production of oncometabolite, which is which is the 2,8-G, which disrupts your cellular processes and contributes to tumor genesis and progression. Oops. Okay. Then there is 1p19q co-deletion, which is essentially a co-deletion which is a hallmark of oligodendroglioma. So if you have an IDH mutant mutation plus you have a 1p19q co-deletion, this kind of is pathognomic of an oligodendroglial tumor. And then there is MGMT mutation. An MGMT promoter mutation essentially is a both prognostic and a predictive marker. It encodes the DNA, MGMT gene encodes a DNA repair enzyme. And methylation of this MGMT promoter region increases your responsiveness to chemotherapy drugs like the temozolomide. So what essentially is happening is that by silencing MGMT expression, there is decreased repair of the tumors of the DNA, which makes them more susceptible for DNA damage and induced cell death. And therefore, the presence of MGMT promoter methylation predicts your increased response to temozolomide and other alkylating agents. Then 2016 also did away with one of the new older entities, and I'll talk about it in a minute. But most importantly, what 2016 did was that, which was a novel concept at that point, was that molecular markers would overrule histology. Till then, histology used to be the prime, and whatever the histopathologist said was the right thing and still is the right thing. But molecular markers are kind of help and aid and differentiate the tumor identities. So this was the 2016 classification, which did away with the oligoastrocytoma terminology and introduced it in line with the embryology, which I will talk about in a minute. So there is astrocytoma, there is oligodendroglioma, and then there is glioblastoma. At that point, we were doing IDH mutation of the astrocytoma and oligodendroglioma, if they were IDH mutant or wild type. If they were IDH mutant and 1p19 cube co-deleted, then we would say that it's an oligodendroglioma. And if it wasn't, then we would say it's an IDH mutant diffuse astrocytoma. The glioblastoma was simply IDH wild type grade 4. And if we didn't do the genetic testing, or it was inconclusive, it fell into no specific type. In 2021, WHO classification of CNS tumors incorporated the molecular information more openly. So we went from discussing tumor classification like this to this, where we were classifying it with more to do with the molecular markers. And in some way, this classification made it more complex, as the EANO guidelines presented a flowchart, which at the outset looks quite complex for making a diagnosis of the gliomas. It basically divided gliomas, both adult and pediatric type, into 6 families, and based on their molecular information, and then also based on the histology, and divided them into grade 1 to 4. Even if we do a more simplified version of making diagnosis and look at adult type gliomas alone, even then they look a little bit complex with IDH wild type mutation. Once you have that, you have to have one more of the following, which is microvascular proliferation necrosis, EGFR, and 7 gain, chromosome 7 gain, or 10 loss, to make a diagnosis of glioblastoma IDH wild type grade 4. And then the mutant types was based on the other mutations. But essentially, what it is doing is bringing the glioma diagnosis in line of the embryology. So glioblastoma grade 4, oligodendroglioma, and astrocytoma are divided into their grades and histology. So just to explain how the embryology works and sits very neatly with these three terminologies, if you understand that all the brain cells are from the common progenitor, and you broadly then divide it into the progenitor cells that make your neurons or the wires of the brain, and then the other progenitor, or the glial progenitor, that makes the rest of the support structure, and differentiate into oligodendrocyte and astrocytes. Oligodendrocytes, as you already know, are the cells that produce myelin sheets, or the insulin coating of the axons. And the astrocytes are the structural support of the blood-brain barrier and the synapses. So they basically are support structures of the brain. What happens is the medulloblastoma is from the neural progenitor cells, and it's the most common embryonal cancer, and or the most common childhood tumor of the brain. The oligodendroglioma is from the oligodendrocytes, or the oligodendro progenitor cell series. And the astrocytoma is similarly from the astrocyte embryonal cell series. And the glioblastoma can be from any of the above. So as I said, it's what the WHO 2021 classification is doing is making them in line with the astrocytoma, oligodendroglioma, or glioblastoma. And that's how it's kind of simplifying it. But as I said, glioblastoma IDH wild type, which was just grade 4 previously, and now has to have more markers with it, and it has to be defined, and is defined now by being IDH wild type, and one of the following, which is microvascular proliferation or necrosis or TERP promoter mutation, or it has an EGFR amplification, or has a chromosome 7 gain or loss of chromosomal 10. Now, coming to the treatment of glioblastoma. The treatment options of glioblastoma remain the same. For now. We have the neurosurgery, we have the radiotherapy, and systemic therapy. And there's no standard treatment for every patient. Like, we don't roll it out just willy-nilly. And apart from there is clinical trials as well. A quick word on surgical options. The surgery is the mainstay, and the objective is the maximal safe resection, and also provide tissue for the histological and molecular confirmation. Only complete tumor resection is a positive prognostic impact on gliomas. If one is not able to do a maximal safe resection, and there is obviously a option of doing just stereotactic biopsy, and that depends on the patient's risk factors, age, comorbidities, and also the tumor localization. Modern neurosurgery has lots of things up its sleeves, including pre- and intraoperative multimodal neuroimaging. Plus, there is a new kit on the board, which I hadn't seen before, is the 5-ALA fluorescence assisted surgery, where on the left you can see that the brain tumor looks the same, but under image intraop visualization, you can see that there is a marker into the veins, and you see the tumor area, and it's shown to improve the tumor localization and help aids in surgery. Coming back to my topic, which is the chemoradiation, the standard of care for a patient who has GBM and favorable prognostic factors, which is a young patient with a good ECOG score, is the STUP protocol, which has been the standard of care since 2005. It basically involves temozolomide given with chemoradiotherapy on the radiation days, and then you get a 4-week break, and then temozolomide is given for 5 days every 28 days for 6 cycles. This treatment is relatively well tolerated, and subsequent to this, everybody tried to improve the temozolomide regimen, but none of those regimes showed any improvement over this STUP protocol. So this is the standard of care, and it showed that there is an improved overall survival and versus radiation alone. I'm not going to talk about radiotherapy much because we have a separate talk about it, but the treatment of GBM is a little bit different and controversial in the elderly. Firstly, because the number of symptoms you have in the elderly, the comorbidities, comorbidity burden, and ECOG status, and also the toxicity profile. The general prognosis is worse for the elderly age group, and the overall survival is about 6 to 10 months. Whereas in the younger population, it's about 15 to 20 months. Also, the treatment part, the EORTC initial STUP study did not include anybody above 70 years of age. So after the STUP for a long time, we did not have an evidence-based recommendation for the elderly. But subsequently, retrospective data and studies have shown that radiotherapy does improve your overall and progression-free survival over palliation alone. And also, there is when temozolomide is added to the radiation, it improves the overall median overall survival. And in certain cases with MGMT methylated tumors where the temozolomide is more active or better active, you can replace temozolomide with radiation as well. This is borne by the fact that there were two trials, the NOAA-08 trial and the Nordic trial, that showed that patients had non-inferiority, which were non-inferiority studies for MGMT promoter methylated patients. Apart from that, in my practice, what I do is individualized treatment in the elderly, and that's based on the tumor location, resectability, performance status, and molecular imaging, molecular findings, and also comorbidities. It boils down to a simple flowchart where we say that we look at after the maximal safe resection and maximal resection or biopsy, you look at the post-operative functional status of the patient. If the functional status is good, you look at the age. Younger patients are treated as normal with concurrent chemoradiotherapy followed by temozolomide. And the elderly group, you have options of giving short course radiotherapy with adjuvant temozolomide, short course radiotherapy alone, or temozolomide alone. In patients with borderline or lower ECOG status, you look at MGMT first, look to assess the temozolomide action and temozolomide importance. If it's methylated, then you give temozolomide. You could give temozolomide alone, and or short course or best supportive care. Or in patients who MGMT is unknown or they're unmethylated, temozolomide wouldn't have much role to play, and you just look at best supportive care or short course radiotherapy. For recurrent, I know I'm running over time. Give me a few more minutes. I'm not going to talk about pseudo progression. I'm sure Dr. Soumya would be talking about it. If the patient generally recurs back, and after recurrence, we have we have treatment options which look the same. You can have a second surgery, or you can have radiotherapy if it's a off-field progression. And then you can talk about, and then we can also do temozolomide rechallenge, PCV, bevacizumab as options of therapy. Bevacizumab, whilst it has shown that if you add it to other chemotherapy drugs, it improves your survival and progression-free survival. But realistically, one uses it as a steroid-sparing agent rather than any major treatment alone. Then there is supportive care that each of these patients need, like the edema therapy, anti-edema therapy, which there is intracranial edema seen in MRIs due to disruption of tissue, blood-brain barrier. The drug of choice is dexamethasone, which we give between 12 to 16 milligrams per day. And because of the multiple problems with the dexamethasone, it's stopped as or tapered as soon as the need is done. Then anticonvulsive therapy is also one of the supportive treatments that these patients need. And primary prophylaxis is not indicated. If the patient is having seizures, one could use levetiracetam or Keppra and lamotrigine. Generally, we avoid enzyme-inducing anticonvulsants like phenytoin and phenobarb. No medical oncology talk is complete without talking about targeted therapies. But however, in brain cancer, or glioblastoma, it's been a list of long failures. BRAF and NTRK recently have shown some activity. However, one is not sure why the most of the targeted therapies are coming negative and not showing much improvement, including the PD-L1 inhibitors, which is the wonder kid these days that we use almost on everybody and every cancer in some form or the other. So, take-home messages. Glioblastoma is the most frequent glioma and the most aggressive one. It has high morbidity, and the median overall survival is about 15 months. The common symptoms include headache, nausea, vomiting, and depends on the tumor localization and tumor size. High ionizing radiation is the only unequivocal risk factor. MRI is the gold standard for evaluation of brain tumors. We now use WHO 2021 classification. Molecular markers are integral to the classification of the brain of these tumors. IDH1 mutant glioblastoma is now called IDH1 mutant astrocytoma, grade 4. The MGMT methylation should be done in elderly, frail patients. The standard first-line therapy is maximal safe resection plus 2 protocol of chemoradiotherapy. And in recurrent tumors, there is no standard treatment, and the treatment depends on on the patient, and clinical trials should be sought for treatments, and supported therapy is standard of care as well. Thank you. I think we're taking questions at the end.
Yeah, thank you, Agarwal, for an excellent overview of the glioblastoma, from the classification, the overview of the treatment. So it's an excellent overview. I request the audience to place their questions in the chat box. They will be taken at the end of the talk. Without taking much time, I will move on to the next speaker, the Dr. Soumya Ranjan. Dr. Soumya Ranjan worked as an associate consultant at Narayana Hospital. His expertise in neuro, head and neck intervention in addition to neuroimaging. He has been trained in AIMS New Delhi, and he has done DM from NIMHANS Bangalore. He's actively involved in advanced imaging-based solutions of neurological disorders. For this, I invite Dr. Soumya Ranjan for his talk on neuroimaging in glioblastoma.
Thank you, sir. Sir, am I audible?
Yeah.
Thank you, sir, for a kind introduction. So I'll be sharing my desktop. Is my screen shared, sir?
Yeah.
So I'll be talking about neuroimaging glioblastoma. So I think there is a demographic representation has already been done. So sticking to the neuroimaging, MRI has always been the modality of choice for the diagnosis and assessment of treatment response. However, the interpretation of imaging studies after treatment of GBM is challenging because you have a lot of responses like pseudo progression, or is it a recurrence, or is it because or is it radiation necrosis? So it's very difficult to come after surgery rather than pre-surgery. So when you come to the imaging for diagnosis, so we start with the conventional sequences. So this is your T2 weighted sequences. You can see there's a relatively well-defined heterogeneous lesion. You can see there is some T2 hyperintensity that is surrounding this lesion in the left parietal lobe. And when you go for, and this is your flare sequence, you can see this is a perilesional flare intensity, hyperintense signal changes over here. And this is your contrast T1 sequence, where you can see there is a thick end of enhancement, ring pattern of enhancement with some foci of internal foci of enhancement. This might be a typical representation of a neoplastic lesion when you see on a conventional MRI sequences. So the conventional MRI sequences can also be used to predict outcomes and survival. Like you can calculate the tumor volume, the extent of the peritumoral edema, or it could be a necrosis or a degree of enhancement as well as presence of cyst. So this is one of the conventional sequence. This is your T2 weighted sequence on my left side. On the right side, this is your flare sequence. These are all the axial sections. And on the T2 weighted axial section, you can see this is a relatively well-defined T2 hyperintense lesion in the left paracentral lobule. And on this flare sequence, you can see there is central suppression of the signal within. So, and this has been found to be associated with microcystic changes, which is seen in IDH mutated 1p19q non-correlated gliomas. So this is your T2 flare mismatch sign. And when you come to the another sequence, which you usually take in a conventional MRI, that is susceptibility weighted imaging. So where we see for the intertumoral susceptibility signal changes scoring, and that is your hypointensity within the susceptibility imaging. So this is one of the representation of a lower grade tumor. You can see this ill-defined lesion in the fronto insular opercular insular region on the right side, and which doesn't show any elevated relative cellular blood volume. And this is your susceptibility imaging. You can see there is deoxygenated blood leptomeningeal vessels. And here you can see there is no evidence of any lower signal changes with such susceptibility signal changes within the tumor. While in this section, you can see this is a very heterogeneous lesion, solid cystic in the left right frontal lobe. And you can see this is an eccentric solid enhancing component within, which is showing raised cerebral relative cerebral blood volume. And on susceptibility, you can see there is huge heterogeneity as well as higher intratumoral susceptibility signal changes. And studies have shown this higher intratumoral susceptibility signal changes to correlate with the relative cerebral blood volume, because this could be a finding of the deoxygenated blood, the blood vessels within the tumor. And this studies have also shown this high ITSS score to be associated with IDH wild type and MGMT unmethylated glioblastomas. And usually this is found in tumors which is arising in close proximity to the subventricular zone. And when you come to the another conventional sequence, that is a diffusion weighted imaging and ADC maps. So this is your classical diffusion weighted imaging at the high V values, where you can see there's a higher signal in the along the corner radiator on the left side. And you can see this is a decreased signal that is in the on the ADC maps, and the corresponding perfusion maps, you're seeing higher signal on the corresponding perfusion maps. So when you have ADC value less than 1000, and which can differentiate high-grade gliomas from low-grade gliomas. And IDH mutated tumors which show better prognosis has a significantly higher ADC values than IDH wild-type tumors. However, there's a caveat when you see the true restriction, since the higher grade gliomas have a propensity to upregulate the aquaporins P4 and P1, which limit the ability of ADC to truly capture restrict diffusion when you have even in a hypercellular background. And this is a other imaging representation. And you can see this is your heterogeneous tumor, which is seen in the right parietal lobe. And this is your DTI reconstruction. This is your diffusion tensor imaging. So this is your corticospinal tracts on the right side, and this is your left side. Left side is your uninvolved. This is a normal representation of the corticospinal tract. And on the right side, you can see there is rarefaction of the fibers along the corticospinal tract at the corner radiata centrum semioval level. And there is also a decrease in fractional anisotropy, which suggests to infiltration along the tracts. And on the superior level, you can see on the medial aspect of this lesion, you can see there is rarefaction in the superior longitudinal fasciculus on the right side. And you can see this cingulate fibers on the right side and superior longitudinal fasciculus also on the right side in the medial aspect of the lesion. So when but there's a caveat to this representative image, that if you have gliomas have a tendency to infiltrate through the white matter tracts, so they would be disrupting the diffusion of water, and they will be resulting in a disruption in the anisotropy. So once we remodel this tensors in mathematical probability functions, there might be an abrupt termination of the tract, which might give a false picture of the involvement of the tracts, and surgeons might go for overboard with resection of the supposedly abnormal tracts. So this is another of the sequence which comes in the advanced imaging. This is a perfusion imaging, that is a dynamic. I'll be talking about three kinds of perfusion. This is a dynamic susceptibility contrast perfusion imaging, and it primarily relies when you give highly paramagnetic gadolinium contrast, when it goes through the capillary bed, because of the T2 star relaxivity effects, there is a loss of signal. So this is your gradient deco sequence. Where this is your pre-contrast sequence. As the contrast bolus is passing through the leptomeningeal vessels, you can see there is reduction in the decrease in the signal surrounding the vessel, and this is a post contrast images. So, but the caveat is being that this is a single compartment vascular model which has assumed contrast to be staying within the vessels. So when you process for the glioblastomas, we have to keep in mind we have to use the proper leakage corrections. Otherwise, the relative cerebral blood volume measurement would be a error on our part. So I'll show you this one classical representation. This is, you can see, this is your ill-defined flare hyperintense lesion on in the right parietal lobe involving the defied matter tracts. And this is your T1 weighted sequence. You can see this is hypointense compared to the normal T1 hyperintense white matter. And this is your post-gas sequence. You can see there is filling up the blood venous sinuses. And here you can see the subtle feathery marginal appearance along the white matter tracts. And this is your delta map, which is used to see such inconspicuous lesions, which like this is a basic representation of a subtraction of the post-contrast from pre-contrast T1 sequences. We can see this is a classical feathery appearance infiltrating along the white matter tracts, which on corresponding ADC is showing low signal, and which one also on the perfusion is showing increased elevated relative cellular blood volume. And this is your MRS, which is a metabolite mapping. And this is your choline peak, and this is your lipid lactate label. So there's an elevated choline peak and lipid lactate level, which is suggestive of high cellular turnover and anaerobic glycolysis. So coming to the second part of perfusion imaging, this is your dynamic contrast enhanced imaging. And this relates on the T1 shortening effect when you pass the contrast bolus through the tissue. So once the contrast passes through an arteriole into the capillary bed, it has to travel to the tissue and back to the venules. So the passage through to the tissue depends on your permeability of the vessel vasculature and the vascular surface area as well as the flow. So this is known as K-trans. This is one of the value which reflects this passage of contrast from the arterial to venous tissue side. This is an increased K-trans value which reflects a higher degree of blood-brain barrier damage and vascular compromise. So, but this the use of the K-trans value in depicting higher grade of or lower grade of glioma is still contentious because there's notable lack of FDA approved or validated post-processing software. So the first section, you can see this is your DC map. You can see this is a K-trans map, color-coded maps on the higher section. Also in the lower section, this is your K-trans color-coded maps. You can see there is a increased color coding when you use the upper section compared to the lower section. While on the other conventional sequence, this looks basically the same heterogeneous with very ill-defined margins with hyper intensity surrounding in the white matter. So this histopathological analysis turned out to be a higher grade compared to this tumor in the lower section, which turned out to be of lower grade because there is a difference in the K-trans value, which is showing elevation in K-trans value in higher grade tumors. And this is your third perfusion sequence. This is your arterial spin labeling and doesn't require any intravenous administration of exogenous contrast agent. And it uses arterial water as an endogenous tracer, so no contrast, no gadolinium. And but it is limited by poor spatial resolution. That is one of the limiting factors when you do arterial spin labeling. So you can see this is this heterogeneous lesion we have already seen in one of the starting slides. And with this is your DTI maps. You can see there is a there is a displaying as well as decrease in anisotropy in the inferior longitudinal fasciculars. And here you can see this is your ASL map, which shows increased cerebral blood flow which corresponding to the enhancing part of the lesion. And coming to the MR spectroscopy, and this is basically depends on the chemical shift to integrate the tissue metabolic environment. And in high-grade gliomas, we will be seeing decreased levels of N-acetyl aspartate, which is basically a neuronal marker, and creatinine, which is a cellular energy marker. And we have increased levels of choline, lipid, lactate peak, which is suggestive of a high neuronal cellular turnover with anaerobic glycolysis. And this is a new MRS algorithm, which is a 2-hydroxyglutarate MR spectroscopy, which is echoed at 97 millisecond of time to echo. And this is used to determine whether the tumor is IDS mutant or IDS not mutant. And this basically this 2-hydroxyglutarate MRS needs good spectral editing to come to a conclusion. And this is your routine MRS. We can see this is a multi-voxel, and they have placed a number of voxels in the enhancing part of the lesion and the left frontal lobe. And you can see this one of the voxel which is showing increased choline peak with decreased creat and N-acetyl aspartate peak with increased lipid lactate peak here. And this is your this is a functional imaging. This is your FET scan, which shows increased SUB uptake corresponding to the enhancing part of the lesion. And this is your 2-hydroxyglutarate MRS. And you can see this is when you have a normal MRS, you can see the increased choline lipid lactate peak. While this but there are overlapping peaks, you can see this is your GABA peak and this is your glutamate near to the spectral of the hydroxyglutarate. And so we have to do a heavy spectral editing to eliminate this crossover of metabolites. And after spectral editing, you can get a 2-hydroxyglutarate at 2.25 ppm, which is suggestive of IDH mutant status of the lesion. So once we come to a diagnosis of the neoplastic lesion, which is suggestive for glioma, glioblastoma, the main concern comes imaging after surgery. So the imaging should typically be performed within 72 hours, and basically to evaluate the extent of surgical resection, potential surgical complication, or to plan radiotherapy. One of the finding is that if you have in the resection cavity, you have increased flare signal changes, which is non-suppressing. They have a high specificity for progression even before tumor size increases. The hypothesis being it might be because of a leaky capillary vessels, which is secreting proteinaceous content surrounding the lesion, surrounding the postoperative cavity. And the caveats being the subacute infarcts, which might mimic progressive tumor imaging because of intrinsic T1 hyperintensity, and other being implantable carmosine if they have been implanted in a postoperative cavity. They're also known to temporarily change signal intensity enhancement within the resection bed. So this history has to be taken up before in the imaging after surgery. And this is a imaging representative image, which is post-surgery. You can see this right parietal craniotomy approach, where you can see this dissection cavity, and you can see there is a heterogeneous signal changes in the thalamus, in the insula, and in the supratemporal gyrus. And on the contrast enhanced sequences, you can see there is nodular enhancement with heterogeneous enhancement in the right thalamus, which is also showing restricted diffusion. As you can see, there's a lower value in the ADC maps with increased perfusion on the with increased relative cerebral blood volume. And an MRS at the same site, which is showing enhancement. This voxel is showing increased choline peak and relatively elevated lipid lactate peak. So this is another representation of a post-operative imaging. You can see this went to the right parietal craniotomy with post-operative cavity. You can see there is no enhancement. While in the diffusion-weighted image, you can see there is a restricted diffusion surrounding the operative cavity, which is because of the surgical manipulation. And on post-contrast imaging, which was done a few weeks later, we can see there is nodular enhancement in the medial margin of the post-operative cavity. So this could be, suppose if you don't see the immediate post-op scan, this might be taken off as a possibility of a reoccurrence or of the lesion. But since this corresponds to the area which has underwent infarction, this should be a granulation tissue which is showing enhancement in this section. So when you come to the assessment of the treatment response, McDonald criteria was the initial method which was used. Currently, Rano and there is quite a significant change how we approach treatment response in glioblastomas. And we can see there is some major differences between these two criteria. In Rano, we have defined the measurability of the lesion. We have taken into account T2 flare hyperintense signal changes within the lesion. And obviously, we have taken the consideration of pseudo progression, which has become more prevalent because of a newer introduction of drug, anti-VEGF drug like bevacizumab. And the other factors being similar, like uses of corticosteroids, clinical status, durability of response, and the criteria of response and progression being similar in both the arms. So this is a brief summary of the Rano criteria for GBM recurrence, where they have assessed like complete response, progressive, stable disease, and partial response, stable disease, and progressive disease. And beyond Rano, we have immunotherapy-related Rano, which was introduced in 2015, modified Rano in 2017, and Rapno in 2020. So when you assess a tumor in the post-operative setting or on a follow-up scan, there will be a lot of pitfalls and mimics because it's not a simple dichomatous thing that needs assess a post-operative imaging. So you can see this is a very heterogeneously enhancing lesion, and this is overlaid perfusion maps on it. You can see few of the areas are showing raised perfusion, few of the areas are not showing raised perfusion parameters. So this is basically a mixture of radiation necrosis with the mixture of tumor cells. So it's not simple to see a lesion in a first go and categorize at either nor or. It's always and in this spectrum. So when you have increased enhancement, there might be some different mimics, like it could be because of treatment-related changes, might be post-rectal changes, post-surgical changes, or ischemia, or it's because of a subacute radiation effects or radiation necrosis. So when you go to the radiation necrosis as one of the entity that we'll be seeing in the post-operative imaging and post-therapeutic imaging, and this is your delayed manifestation of tissue injury, which occurs 3 months to 1 year following radiotherapy. It might also manifest several years following radiotherapy too. And this is because of a disruption of the blood-brain barrier, occlusive vasculopathy leading to thrombosis and ischemia. So this is basically a safe in wolf's clothing. And you can see this is already a proven case of radiation necrosis. You can see there is a very feathery type of enhancement in the subventricular zone and the deep white matter in the left corner radiata. And also you can see this is a second representation. You can see some nodular enhancement pattern in the lateral margin of the section cavity, which in perfusion imaging doesn't show any elevated relative cell blood volume. So when you see a development of a lesion in an area of radiation-induced leukoencephalopathy or previously non-enhancing tumor with minimal to mass effect, then that might be a suggestive of radionecrosis. And radionecrosis have a predilection for the subventricular zone, since this is being supplied by your long medullary arteries. And this because of the poor supply and lack of collaterals at this point, it has a more propensity to undergo radiation necrosis. This is your first section. You can see this is your 20 months after surgery and radiotherapy. And this is your post-resection cavity in the left frontal lobe with some T2 hyperintensity signal changes just posteromedial to it. And on contrast enhanced sequences, there is no evidence of any enhancement surrounding the cavity or within the cavity. However, 26 months after treatment, we are able to see there's a drastic change in the T2 hyperintensity, which has also involved the opposite cerebral hemisphere. And also there's a lot of heterogeneity within the white matter tracts. And in contrast enhanced sequences, you can see this is basically something that we call in a typical radiation necrosis, like a soap bubble, a Swiss cheese appearance. However, we have to do a perfusion imaging to distinguish between these two. So on the perfusion imaging, there is no elevation of relative cerebral blood volume, which is more of a radiation necrosis now rather than a recurrence of the lesion. So however, the life is not simple. So this imaging also, this is a overlay of relative cerebral blood volume maps with the contrast sequence enhanced sequences. We can see this the contrast enhanced part of the lesion, which is not showing increased perfusion parameter, while here you can see there's a elevated perfusion parameter. So at this section, this is a admixture of neoplastic cells as well as concomitant radiation necrosis. And when you go to this other representative case, you can see this is your postoperative cavity, and this image has a newly introduced flare hyperintense signal changes, and there is some nodular enhancement posterior to it, posterior to the cavity. And this might be taken off as something of a radiation necrosis also, but we have to assess with the other conventional sequences too. And you can see this is your DTA tracks. You can see this along the callosal fibers. When you compare to the contralateral side, you can see there is a decreased fractional anisotropy with the disruption of the fiber tracks. So it's more likely this will be a malignant which has gone infiltrated into the white matter tracks. So this is your classical representation. This is a textbook kind of thing, which is like your solid enhancing part, showing restored diffusion, elevated colon. And this is your other lesion, which is very heterogeneous, a serpentinous pattern of enhancement. On the first look, it might be taken off as a radiation necrosis, but when you see the perfusion imaging, it's highly elevated relative cellular blood volume. So these 2 points which negate this recurrence versus radiation necrosis, like if you have elevated lipid lactate peak on MRS without elevation of choline, more likely radiation necrosis. We have a low normalized cellular blood volume ratio, more towards radiation necrosis. So coming to the second entity, this is a pseudo progression, which is seen in 20 to 30% of the patients. And this is within 3 months of completion of radiotherapy with concurrent temozolomide therapy. So the mechanism being very poorly understood, and MGMT methylated tumors have a higher incidence since they are more sensitive to the temozolomide. And studies have shown in this subgroup of patients, the median survival somewhat improved if correctly identified, and it typically stabilizes the results without any corresponding change in treatment. So before coming to the pseudo progression versus progression, I just want to talk about the bevacizumab. This patient was treated with bevacizumab. We can see there's a distinct persistent diffusion restriction surrounding the post-operative cavity, and this is a T1 image pre-contrast. We can see there's intrinsic T1 hyperintensity surrounding the lesion, which can be induced through bevacizumab. And this is post-contrast image, which is very difficult to ascertain, is it a true enhancement or is it because of intrinsic T1 hyperintensity, which where the delta map, T1 maps will come handy. So when you differentiate between this pseudo-progression, we have a lower ADC cutoff as well as a median CVV relative cellular blood volume cutoff, which differs from study to study because of heterogeneity in processing softwares. So this is a brief summary about the radiation necrosis versus pseudo-progression. Radiation necrosis usually typically occur within 1 year.
Dr. Soumya, can you sum up?
Yeah, sure, sir.
Yeah.
The 1 year to several years, and the pseudo will be weeks to months. And this is more of an irreversible kind with profound neurologic decline. This is a transient outcome with favorable prognosis. And pseudo response is a wolf in sheep's clothing, and this is basically seen with the treatment of bevacizumab. And you can see this is an initial scan where you can see there's a strong expansile hyperintense lesion over here. And you can see the heterogeneous enhancement following bevacizumab. There is decrease in enhancement and edema, which might be seen as a good outcome. But however, following few weeks later, the interval scan is showing increased flare hyperintensity and also increase in enhancement. This is not basically a resolution, rather than this is something of a wolf in sheep's clothing appearance. And this treatment with VSO doesn't confer survival benefit in this kind of patients. And these are the emerging imaging techniques, that mass spectrometry imaging, which can discriminate glioblastoma cell subpopulations. And this has come up recently in the Nature journals, where they have identified the ganglioside-acted immunotherapy and membrane lipid therapy in relation to the lipid profiles in the glioblastomas. And this is where your artificial intelligence comes into play, where you go into radiogenomics and texture-based analysis to go for a individualized or personalized therapy in a patient with glioblastoma. Thank you, sir.
Thank you, Soumya. For a comprehensive overview of the imaging in glioblastoma, you have highlighted almost all the advanced MR imaging technique, including a brief overview of the AI. Since we have a limited time, so thank you. I request the audience to place their questions in the chat box. And now I invite the next speaker, Mr. Rakesh Kaul, who is working as a chief radiation therapist at Max Center, Cancer Center, Saket, New Delhi. He has published many publications in the national and international journals. Mr. Rakesh has presented more than 400 presentations at national and international conference. With this introduction, I invite Mr. Rakesh to talk on radiotherapy management of glioblastoma.
Thank you very much for the nice introduction. I'm privileged to get a chance to be the part of this special session. And my thanks goes to Dr. Anju Agarwal, Dr. Vyas sir, Dr. Chirag sir, and of course my sincere thanks to Vinita Sharan and Mrs. Suresh. Now I'll just present my presentation. Just give me a minute. Is it okay?
Yeah.
As we know that that there are different treatments for this, but today I'm going to speak because I'm a non-clinician and I'm going to speak about the radiotherapy management in the glioblastoma. So as we know that GBM is a fast-growing and aggressive tumor of the brain or spine. GBMs almost never spread outside the brain, spine or CNS to other parts of the body. They are very challenging to treat because of their complex nature. Now, GBMs present unique treatment challenges due to the localization of the tumor in the brain, inherent resistance to conventional therapy, limited capacity of the brain to repair itself, and tumor-induced seizures, migration of the malignant cells into the adjacent brain tissues, and peritumoral edema and intracranial hypertensions, and the resultant neurotoxicity. These are some of the challenges which we see during planning the radiotherapy. So as we know the symptoms that has been explained by other speakers also, there's a persistent headache, double blood vision, vomiting, loss of appetite, change in mood and personality, change in ability to think and learn, new onset of seizures, and speech difficulty. Now, there are the diagnostic tools. They can accurately pinpoint the location of the brain tumor. That imaging tools which are we are using for locating tumors are the CT scans, MRIs, and for the intraoperative MRI may also be useful during surgery to guide tissue biopsy and tumor removal. And the MRS is used to examine the tumor's chemical profile so that we can pinpoint the location of the brain and the chemical profile of these tumors. Now, looking at the glioma, that we have subdivided into two categories. That's a low-grade glioma and the high-grade. Now, low grade, it has been again subdivided into two parts. That's the asymptomatic and the symptomatic. When it's the asymptomatic, so we have to keep this under observations. When it is symptomatic, then two things may happen. There's a chronic non-progressive. When it's a chronic non-progressive, then we keep it under observation. But it is a chronic progressive, then the treatment options are the these are the treatment: surgery, radiotherapy, and chemotherapy. These are this. But so far the high grade is concerned, we don't have to keep under the observation, but straight away to choose these three options out of the three. So what the treatment is to be given. So now if we summarize that, we have the options like symptom management, surgery, chemotherapy, and radiotherapy, as Dr. Vinod was already said. That radiation therapy plays a critical role in the management of the brain tumors. So I'm purely going to speak about the radiotherapy part. Now, what is our aim in the radiotherapy? As we know, the radiation oncology has experienced the greatest technological advance in the recent years, enabling decisive progress in clinical practice and in achieving of the primary goal. That primary goal is to achieve our tumor control by delivering the homogeneous radiation dose to the tumor-bearing tissues, and to avoid radiation-induced complications by minimizing dose to the normal tissue structures. As has been said, that necrosis can happen and other things can happen. And if we this aim is completed, then we can increase our dose conformity, and we can spare our the tissues also, and we can also decrease our reduce our plant complexity, and treatment time and scattered and leakage radiation can be also reduced by using these highly advanced machines. Advanced technologies can be used for therapeutic purpose, allowing revolutionary cancer treatments with high precision techniques, because there are different techniques which are involved in treating the brain tumors, and we have whatever is the best technique we need to understand depends upon what is the location of the tumor in the brain. So this is a three-dimensional conformal radiotherapy, intensity modulated radiotherapy, and image guided radiotherapy, which is one of the which can be used in associate with IMRT and 3D CRT. And multi-leaf collimation depends upon the leaf thickness, and helical tomotherapy, which is the latest one, where we can treat the tumor slice by slice, and volumetric modality arc therapy. In our language, we call it a VMAT or rapid arc, and stereotactic radiotherapies also. These are some of the latest technique available, and we are at our center we are using all these techniques fully, and we have explored it. And as we know, in addition to the technological development in the field of radiation therapy, there has been an advance in the imaging technology also, coupled with the advances in the computer technology. When I say the advance in the computer technology, I mean the softwares which we are provided by the companies, or the artificial intelligence. It has increased our ability, our skills to delineate the tumor and localize the tumor, and also spare our this normal tissues as well with these using these imaging technologies. So CT, MRI, and one of this image fusion, which is very important in the delineation of the tumor. So we are going to discuss that one. These things have led to the significant improvement in the accuracy of targeting the tumors, improved outcomes, and better quality of life for cancer patients. Now, even if we are using the IGRT technique or different techniques, but there are unintended deviation in patient setup or residual interfraction motion cannot be completely eliminated. Even we are using all these techniques for the patients. Sometimes the conformity and precision becomes more difficult to achieve due to various reasons, and that reasons can also harm the patients, because if we are not using our technology or imaging during the treatment, that may either the target receiving the less dose, that means we are not delivering the proper radiation dose or prescribed to the target, and the critical structures receiving the additional dose. So it could happen the reverse. So it is advised to use the imaging during this integrating imaging system, which is available in the linear accelerators or in the helical tomotherapies. So usefully it, so that we can deliver the radiation precisely. So if we want to do this, the same can be achieved by accurate patient positioning, which is very one of the most important things, coupled with the onboard imaging platforms. We have two imaging platforms in our this Linux. There's an exact track imaging provided by the Brain Lab system, and the cone beam CT, which is KV or MV CT systems can be used. Now, as I told about the image guidance radiotherapy, what actually it does, image guidance reduces the geometrical uncertainties, and when geometrical uncertainties are uncertainty reduces, so that way we can reduce the PTU margins. PTU is the plant target volume margins we can reduce. So if we can, we are able to use this technique, so we can reduce the normal tissue toxicity. So that means we can reduce the this field PTV margins we can reduce. So that means this leads to reduce the toxicity, and we can escalate the dose also, and the outcome will be the improved local outcome. Now, going to the radiotherapy part. So I am this is the from patient immobilization, CT simulation, image registration, tumor delineation to the treatment deliveries. We have different steps from planning to delivery. This one, and these are some of the guidelines for this one. Now, first part is that patient. Once the patient is recruited for this radiotherapy treatment, so the patient requires high precision immobilization to reduce the movement during the treatment, which is very important, because without immobilization, because had is such a thing, there could be that rotation will happen, flexion and extension of this, because this GBM patients, they are not conscious, so we have to fix them properly so that they can't move during the treatments. But still, if they move, but we can see with the image guidance and correct during the online verification, and move the coach and deliver the treatment. So we have to be very that immobilization should be very highly precise, and it should be comfortable and reproducible on the daily basis. And these immobilizations should be compatible with CT and MRI, because we have to do the planning part of this with these two modalities. So different immobilizations are available to immobilize the patient by different vendors. But at our center, for each patient, we are using 3 single layer masks, as you can see this one. And then for this stereotactic therapy, we have 3 layer masks, which is very highly accurate. And we just put a proper labeling on the cast, what the patient's name, their registration number, date, everything is written, age and sex is also written for identification, because we are going to use these casts for next 30 sessions for the patients. So proper identification is very important. So CT simulation is the another second part. So patient has to be planned in the spine position. Thermoplastic mask is put on the patient's head. Fiducial markers, you can see this one, are placed on the this orthid cast for reference. When we take the reference, we should know where we have put the fiducial markers, as these fiducial markers is the reference this, and accordingly we move the coordinates when we implement the treatment plan. So alignment on the CT coach is done with the help of the room lasers, that's the green lasers, so that the patient should be quite straight on the coach. It should not lie in a different position. And when we take the CT image from vertex C3 level, and 1.5 mm to 3 mm slice thickness is chosen for these images, and we give contrast once the this KFT report is normal. Then these CT images are transferred to the treatment planning system, and where these CT images are fused with the MRI images, so that good delineation is done and good plan is generated by medical physics in consultation with the radiation oncologist. So I'm talking about the image fusion. What image fusion is actually? These are the image fusion between the MRI and this one CT. So it's actually a mutual information is obtained by registration of and fusion of images achieved manually or automatically. As I told that that advancement in the computer system and in the artificial intelligence has taken place. So these softwares we have these help us to for fusion purposes. So now let's look at the these are the that is IR, it stands for the image registration. You can see I have taken 2 pictures. That is, one is the image of the CT, and has then it's the image of the MRI, and is the fusion. Now you can see we have delineated that this is the gross tumor volume, then clinical target volume, and planning target volume. And the same thing is applied on the MRI system also, that we have delineated this one. Now we can see what is the difference. Now CT image shows a tumor with unclear edema, boundaries insufficient or not enough sophisticated for the best treatment delineation. While MRI revealed tumor with clear boundaries of edema. And now if we look at the summarize it, so CT MR fusion is better boundaries of the tumor compared to the CT alone, provides more precise delineation, localization of the edema surrounding normal tissues, which enables more precise determination of the target volume. Without MRI, neither is GTV, that is the gross tumor volume, neither the clinical target volume would be appropriate due to the inadequate usualization. So now coming about the contouring guidelines in the brain tumors, we are using these European Organization Research Treatment Guidelines, that is EORTs, or RTOG, that's a Radiotherapy Oncology Group guidelines. And both these guidelines have different approach to delineate target volumes in glioblastoma. And there is one more guidelines which I'll talk about this one. Now looking at the RTOG guidelines, they deliver the treatment in 2 phases. That is phase 1, where they give the 46 gray in 23 fractions. In phase 2, they give 14 gray in 7 fractions, and we normally call it the boost dose. And in let's look at the phase 1. Phase 1, when they this create a GTV, that's a surgical resection cavity plus residual enhancing tumor, plus surrounding edema, is taken into consideration. So CTV, when we create a CTV, CTV is a GTV1, that is this one, plus 2 centimeter margin is given if there is no edema, but if there is a edema, 2.5 centimeter is given for the CTV. But for this setup errors and other things, we give PTV. Sorry, we give PTV, that is CTV1 plus 3 to 5 margin is given for setup errors. And when phase 2 is given, so we give a GTV, the surgical resection cavity plus residual enhancing tumor. No surrounding edema is taken into consideration. So CTV2 is generated, that is GTV2 plus 2 centimeter margin is only given, and PTV2 is given CTV2 plus 3 to 5 centimeter margin is given. But in case of URTC guidelines, directly there is no boost dose. They give 60 grain, 30% directly, and they give GTV, that's a surgical resection cavity plus residual enhancing tumor. And CT is created GTV plus 2 centimeter margins, but they give 5 margins from different directions, that when the tumor is towards the ventricle side, frog side, and other sides when they feel that necessary they can give. And towards the skull sides there is no margin. Towards the brain stem they keep a 0 margin because it's a critical organ. So then PTV is again this for setup errors, that is CT1 plus 3 to 5 margins. 3 to 5 margins is depends upon the what the this institution to institution that varies. Even some other institutions give 7 markers margins because they don't do daily imaging. Now these are the some other images delineated. That is this is GTV. Then they have given 2 centimeter margin and for setup to 3 to 5 hours. So these are some other delineations how they delineated the tumor. Now there is a 2023 guidelines, is a ISTRO guidelines, that is this neuro-oncology guidelines. So they have different guidelines is same, but only the thing is they give 1.5 margins to create a CTV, and for PTV they give only 3 margins. They have kept the tight margins, and they don't give 2.5 margins. So this depends. But again, in India, some of the centers they give 3 to 5%, 5 margins per PTV. Now, organ at risks. This is one of the critical things, because when we deliver the radiation, the organ at risks are delineated, organ at risks comes into the picture. So due to the complex anatomical relation between the tumor and critical structures such as optic nerve, optic chiasm, retina, brainstem, cochlea, and hippocampus, and so many other things, they come into the picture. We need to save them. We should not exceed the dose to these critical organs, because then we face different difficulties. So it is nearly impossible to prevent partial radiation of these structures. So, but remarkable progress has been made with respect to the visualization of the tumors for treatment planning purpose and highly accurate radiation dose delivery by these imaging technologies. So we have been able to prevent these dose to the critical organs. Now, optic nerve, this is one of the critical organs. Optic chiasm is one of the critical organs. Hippocampus. So these are some of the cochlea. These comes in the picture. These are some of the these are critical organs, and these are the normal dose. The normal tissue tolerance for these is given by one of the these guidelines. They have tolerance doses, like for lens is less than or equal to 10, optic there is a less than or equal to 55 gray. So they have given, so we have to follow these guidelines, so that we should not exceed these doses as per the guidelines. Now there are now some peculiar or unique situation arises. You can see this one. This is the tumor, and pink one we have delineated it, and there is a one blue line, that's the PTV. We have given 1 margin. We can't extend, normally we can't follow these guidelines in this case, because if we follow the guidelines, then we have to extend the field by 2 centimeters. If we are going to extend the field by 2 centimeters, then the brain stem is irradiated, This is optic chiasma is there, and optic nerve is again here. So we are going unnecessary doses this one. So in this picture, we can keep just 1 mm PTE margins, deliver it. But the thing is that we should do this image guidance on daily basis, and this delineation should be proper. Then only we can be, otherwise we can lead in a trouble. Now the treatment planning part, this after delineation of the tumors, after following these guidelines, the treatment planning. After image fusion, target volume and organ addresses are delineated, isocentered placement is done, collimator selection is done, collimator selection of the field, field is defined, dose optimization and is analyzed, which part is receiving how much dose, and plan is evaluation is performed, and this is done by medical physicist and in consultation with radiation oncologist, and these guidelines are followed, RTOG and EORTC. These are the planning images. Now, when we implement the plan, that as I told that we have these different image modalities. We have one of the best image modalities, that is the exact track. This what exact track actually provides. Exact track provides a fully integrated robotic this one module that allows patient positioning all 6 degree of freedom with an improved setup accuracy. Actually, these are the tubes on the floor of this, and these are this flat panels where that images are taken remotely, and this is the 6-dimensional coach, which takes care of that it corrects the patient position in 6 dimensions. That means it takes translation as well as the rotational errors into consideration. After doing these images, we can use this one. So patient setup is also done with this help of the exact track. These are the when we take the image that this patient is moved automatically to the isocentric position. Then images are taken, and these are the setup errors you can see here. These are within the tolerance level. These setup errors we note down and move the coach, enable the 6-dimensional coach of the exact track. When it is so it gives the direction that it's everything is okay, we can proceed for the treatment. But at our center, we do dual image, that's the exact track image, and followed by cone beam CT image are taken to verify and ensure that they are matching with the reference image. Necessary corrections are applied if required before treatment is delivered. During the ongoing treatment, because the patient may
Mr. Rakesh, can you sum up?
Yes, it's a hardly 30 seconds.
Okay,
so we take keep the treatment within 1 mm. So these are the CBCT images. We verify on the this platform, and when it's corrected, we move the patients. So treatment is after image and snap verification, setup errors are noted and coach is shifted. Treatment is delivered as per the dose prescription. Possible patients involuntary motion is monitored. During the ongoing treatment, snap verifications are taken so as to maintain our treatment accuracy within 1 mm. So side effects of this radiotherapy during radiotherapy is nausea, vomiting, dizziness, headache, and hair loss, and it is managed by on the weekly basis in the weekly OPD. So in conclusion, improved technology and more complex treatment in modern radiotherapy can be fully exploited if high level of accuracy and reliability in dose delivery is achieved. IGRT offers a possibility of significantly enhancing the accuracy and precision of radiotherapy and limit the dose to the critical strictures. And we have to follow the protocols and procedures and guidelines. Qualified quality assurance and skilled professionals are required. And thank you very much. This is my home, and I belong to Kashmir. So these are the things. Thank you very
much. Thank you, Mr. Rakesh, for a detailed overview of the radiotherapy management and glioblastoma. I understand this was an interesting topic, but because we have a limited time. So, Dr. Chirag, do we have any questions?
Yeah, so I was just looking at the chat box. There aren't any questions, but we can invite questions. We will maybe just a couple of them because we are already running short time.
Yeah.
So maybe some quick questions if someone has. You can please raise your hands or put it up in the chat box.
So meantime, Soumya, I have one question for you. Which perfusion technique you use for for the GBM routinely?
Dynamic susceptibility, sir.
DSC. Do you use DC? No.
No, sir. No, sir. DSC is a more common we're using, sir.
Okay, we also tried to use it way back, and then we left it. So ASL, do you use quantitative
Yes, sir,
ASL?
sometimes we use, sir. Especially sometimes we do in when there is a lot of hemorrhage or something.
Yeah. Okay.
For ASL.
In a post-op imaging, and that's a good role in a post-op imaging and using a tumors which have a high hemorrhage. Okay, and what about the any experience with the spectroscopy with HG spectroscopy?
HG we used to do as a part of a research workup, not a routine workup.
Okay.
So that was basically part of someone's PhD thesis while doing DM.
Okay.
And that done.
Okay.
Routinely, we're not using 2HG spectrums.
So I think if you don't have any more questions, I would like to thank you, Dr. Sameer, for carrying out this session.
Thank you.
I know it was a kind of a very wide topic, but all the speakers touched their parts very appropriately, and I must thank all of them. Now it is my pleasant duty to invite and introduce Professor Subramaniam K. Betagiri. I hope he is here.
Yeah, can you hear me?
Yeah. Hi, Dr. Subramaniam.
Thank you.
Hi. So, Dr. Subramaniam is a board-certified radiation therapist who's practiced in Jamaica, the UK, and the US. And Professor Mania, as I was told, he's also called by Professor Mania. So he completed advanced placement radiation therapy program from the Loma Linda University in California and is currently working on advanced radiotherapy and oncology practice postgraduate program at Sheffield Hallam University in the UK. So he is also currently the professor and the clinical coordinator for radiation therapy program at Health Sciences Education and Wellness Institute at Bellevue College, Washington State, USA. So I would invite you for the closing remarks, Professor.
Thank you, Dr. Chirag. I thank you so much to Dr. Vinu Agarwal for providing us with the latest updates on glioblastoma multiforme, and Dr. Soumya Ranjan for shedding light on neuroimaging in glioblastoma, and Mr. Rakesh Kaul for sharing insights into radiation therapy management for this condition as well. I also thank Dr. Anju Agarwal for her opening remarks and Dr. Chirag Ahuja for effectively moderating today's proceedings, and Dr. Sameer Vyas for chairing this impactful event. I want to acknowledge and thank the leadership of both Global Association of Physicians of Indian Origin, GAPIO, and the Global Association of Radiological Technologists of Indian Origin, GARSHIO, for organizing such an enlightening discussion on the diagnosis, treatment, and management of glioblastoma multiforme. Special thanks to the IT team for their technical support in ensuring the smooth running of this Zoom event. Most importantly, I want to express my appreciation and gratitude to everyone who has contributed to making this event a resounding success. Your dedication and expertise are instrumental in advancing our collective understanding and approach to tackling glioblastoma. Thanks to everyone for this profound discourse. Have a wonderful night. Enjoy the rest of your day, depending on your time zone. Take care of yourself and take care of each other. Thank you.
Thank you.
Thank you so much. Thank you. Bye-bye.
Bye-bye.